Hello, good day. My name is Jack Colin. I'm one of the moderators of this session. I think it will be a promising session, seeing the cases that will be presented. First of all, I'd like to introduce my co-moderator, Dr. Aaron Sung Lung Wang, and then the distinct panelist, Wai Ting Wang, I hope my pronunciation is correct, Vincent Luc, and Mutulu Fural. And it's also now my turn to do the introduction of the first presenter, Dr. Asushi Sugawara from Japan. And he will discuss the iliac stent dislocation during a TAVI procedure. Please.
Okay, great. Thank you very much for the introduction, Dr. Colin, and good afternoon, dear colleagues. Again, thank you for having me in this great session, and I'm delighted to present our case, which is about one potential complication during transcaster aortic valve replacement, TAVR. So I'm gonna start present our case. He is 81 years old gentleman, and the patient was referred to us because of increasing dyspnea and was diagnosed with severe aortic stenosis. The aortic valve was calcified with aortic valve area of 0.9 quadrat centimeter, and AV function was fairly reduced. He also had a background of peripheral artery disease, or PAD, and had received 2 stents in both iliac arteries. Here you can see the CT image. It seemed that the stent in the iliac artery might not be fully attached to the vessel wall, but the inner diameter of the stent was roughly 7 to 8 millimeter. So we decided to perform transfemoral TAVR via the right femoral artery because of the advanced age of the patient and also multiple comorbidities, as you can see here. And the patient was deemed as at high risk for surgery. And we chose a 34 millimeter Evolute Pro Plus system, which is 18 French inline system, and requires 5.5 millimeter diameter of the vessel. The procedure was performed by our guest doctor from other clinic who have just started to learn TAVR procedure, and the delivery system went very well, actually. And the implanter was about to implant and deploy the device, but I said, wait, stop, because it turned out that there was something on the TAVR device. Here you can see our stent dislocated from the iliac artery along with the TAVR system. So we tried to get the wall system back, but while retracting the system, the iliac stent remained in the distal aortic arch. So what we did was we put a 18 French cis in, but the cis was just a 30 centimeter long, so it was able to reach just above the aortic bifurcation. So we introduced additionally an 11 French cis in, which was 75 centimeter length. And therefore we introduced a snare system. So it was like a mother-child technique in PCI. And we delivered a snare system around the confida wire on which the iliac stent was located. And we were able to catch the stent, the distal part of the stent, but failed to take it back to the 11 French cis in, because the snare got detached from its caster shaft while putting the system back. So we delivered a second and larger 30 millimeter snare system to catch the middle portion of the stent. And finally, the iliac stent was successfully extracted through the 18 French cis. And here you can see the system of mother-child technique, and here first 18 French cysts, and here you see 11 French cysts, and here through we introduced our snare system to catch the iliac stent. And on the right-hand side, you can see here the stent extracted from the body. And interestingly, although the stent had been implanted 5 years ago, the stent was rarely endothelialized. And after that, we performed a transfemoral TAVR via the right femoral artery. Of course, we didn't have any more stent, so no more concern about stent dislocation whatsoever. And thankfully, we didn't have any hemodynamic instability or bleeding from iliac artery. And this is the final result of TAVR, which was very nice. I think there are two messages from the case. Their case tells us that the iliac stent can be dislocated during a TAVR procedure, especially in case of incomplete stent apposition. This is important to know because aortic stenosis and PAD often coexist, and there is therefore increasing potential to do transfemoral TAVR in patients with stent in their iliac arteries. So pre-procedural CT assessment for the stent apposition would be also paramount. Also, mother-child technique may be safe and feasible to facilitate capturing and stably retracting the dislocated stent. So in conclusion, our report describes an instance of iliac stent migration during transfemoral TAVR. That dislocated stent was successfully extracted with a snare supported by a mother-child technique using a combination of 11 French and 18 French cysts. Thank you very much.
Dear panelists, does any one of you have a question or remark? Otherwise, I have first one or two questions. First question is, did you predilate the aortic stenosis or not? Or might that have helped in a case?
We direct. Oh, no, we didn't. We directly implant a TAVR device without any predilatation.
Yeah, I think you did a beautiful job, but I'm thinking to learn a lesson from this, and I do understand what you're saying. I do describe your conclusions, but then my second question raises, did you consider another way to do it, for instance, through the subclavian artery or another route, seeing that this patient had not fully post iliacal stents?
I think from our experiences, it's normally it's gonna be no problem for transfemoral TAVR, even in patient with iliac artery stent in the iliac artery. But I think that we should have considered other access routes, as you said, for example, transaxial TAVR was also something. But
whatever. But
we tried. Yeah. We tried to transfemoral.
Anyone else who wants to ask a question?
Yeah, beautifully done. Only one comment I would like to make, that I presume that this stent must have been about 8 French or 9 French. And it was, once it was dislodged, it was of the confida wire. And we use the mother and child technique. But would we have passed a peripheral balloon inside the stent in the aorta, inflated it at low pressure, and taken the whole assembly down back into the iliac? Would that have been a possibility?
Sorry, acoustically, so I didn't understand well. So your question or comment was, sorry?
We pass the balloon. We take a peripheral balloon, about 6 millimeter balloon, over the confida wire, inside the stent, dislodged stent, in the ascending aorta, inflate the balloon, so that would capture the stent. That would anchor the stent, and the entire assembly with the balloon and stent would have been retrieved. Was that a possibility?
Yeah, good comment. Thank you very much. That would have been a good choice to manage this complication. Yeah, thank you. Yeah, definitely.
Thank you.
I think it's a very interesting case. I think you are very astute in checking the TAVI valve before it deploy. I can't imagine what would happen if you deploy the TAVI valve and actually it was within the iliac stent. So I think it's very good case that you actually can pick it out. Now the other thing is this. Would you have found that it not fully endothelialized? Would you have tried attempt the left iliac, left femoral rather than the right one? That, I think the left side also have a stent inside as well, right?
Yeah, definitely. Yes, as you said, in the left side, we had also iliac stent, and also the stent was also not fully opposed to the vessel. And the tortuosity was more severe in the left side. So we decided to go right side.
Did you do a final angiogram to check whether there's any injury?
Yeah, we did.
To the femoral artery.
We did. And fortunately, there was no stenosis more, no bleeding anymore. So we have just left. So we didn't implant any more stent there.
Do you think that dilatation of the iliac stent is an option if it is not self-expandable before delivering aortic valve?
Yeah, that could have been a good option, as you said. Yeah. Actually, we should have done. Because the CT shows already the malapposition of the stent. So we should have done pre-dilatation of the iliac stent. That would have been more easy or safe way to manage this patient. Yeah, definitely.
But the thing is, you don't expect that the stent will actually
No.
Yeah. Okay. Thanks very much, Dr. Sugiara, for a very interesting case. So it's my pleasure to introduce the next speaker, Dr. Mugilan Sundaraju from National Heart Institute, Malaysia, on the topic, the Squid Game, IVUS-guided angioplasty in a case of spontaneous coronary artery dissection presented with ventricular tachycardia post-COVID-19 infection. Dr. Sundaraju, please.
Good day, everyone. I'm Mugilan Sundaraju from the National Heart Institute of Malaysia. It's a pleasure to be with all of you today. And the case that I'm going to present is called the Squid Game, IVUS-guided angioplasty in a case of spontaneous coronary artery dissection presenting with ventricular tachycardia. So I have no disclosures. So just a background history about this patient, a middle-aged gentleman with very well-controlled diabetes mellitus HbA1c of 6.3 came into us with palpitations and also shortness of breath. It's no need to say that he's actually just recovered from COVID-19 infection, category 2, just 2 weeks before presenting to us with ventricular tachycardia. So the chest X-ray done was clear, shows that there's no evidence of any fibrosis or any lung damage from the COVID-19. Echocardiography revealed a low ejection fraction of 35%, somewhat a good RV function, and also BP slightly on the higher side, 152, 104, and patient was tachycardic at 174. So at this juncture, we gave the patient IV amiodarone 300 milligrams stat and subsequently cardioverted. Post-cardioversion, we realized that the ST elevation over the inferior leads became more and more evident. At this juncture, patient was actually having more and more chest pain and difficulty in breathing. So in view of ongoing ischemia, ECG changes, we realized that we need to do something about it. We brought the patient to our catheterization lab. Looking at the left angiographic shot, we realized that the left main, LAD, the circumflex were actually quite smooth, and there were multiple linear defects over the RCA, which I've depicted here with the blue arrows. This is extending from the mid-segment of RCA all the way to the posterolateral branch. We do know that we are dealing with a type 1 spontaneous coronary artery dissection here. So we decided to go ahead with angioplasty. We did PCI to RCA via the right radial approach using a 6 French SAL1. So we wired down, our workhorse wire was actually filled the FC. We wired down the RCA, but the problem that we're having here is that it kept tracking into the false lumen. So we kept the filter FC there. Using parallel wiring technique, we brought down a filter XT further down to the true lumen. So we wanted to use the IVUS guidance to visualize further, but the problem is even the IVUS catheter couldn't go further down the distal segment of RCA. So subsequently, we wired down filter XT to the RPDA branch. We assume this to be the true lumen. So when we wired down the filter XT down the RPDA branch, we did small, very gentle predilatation with a view rate to 5 mm to about 4 atmospheric pressure. Then subsequently, we realized that there was no flow over the PL branch of RCA. And we rewired back the RPDA, which we once again assumed it was in the true lumen. So to confirm everything, we had to get IVUS done. So what you can visualize here at the mid segment of RCA, there was evidence of dissection. And over here, we can realize that there is some amount of hematoma and further dissection flap further down. So we did wire down with the filter FC to the PL branch, and this was actually IVUS guided. It made our life much easier. We further predilated the lesion with the Sapphire 31515 just at nominal pressure, and we wanted to confirm everything. So IVUS did reveal that we were truly in the true lumen, and further predilatation semi-compliant balloons were actually done. So after further predilatation, we decided to go ahead and instead of stenting the distal PL and also the RPDA, we decided to put a drug-coated balloon, a 2530 mm over the RPDA and a 22530 mm over the PL. And extending from the mid-segment of RCA where the dissection started all the way down, we decided to stent this with a Zion Expedition 3048 and deployed it at nominal pressure, extending all the way to the distal RCA. And this is the final results that we got. Realize that there is symmetry flow. There's no evidence of any dissection that's visible here. So we did another IVUS run. We realized that the stents were actually well opposed, no evidence of stent-edge dissection, and there is the IVUS actually confirmed that the dissection flap is sealed and there's a concealed hematoma. Basically, looking at the MSA at the mid RCA, there was 9.68, and the IVUS realized that the findings basically fulfills all the 3 criteria from the ultimate trial. From here, you can see the yellow arrow actually shows the sealed dissection flap and the concealed hematoma. So things to actually discuss here is that what is very interesting in our case is that we are dealing with someone who just recovered from COVID-19 infection. Yes, it's only category 2, but it's postulated that COVID-19 infection somewhat can cause intense inflammation and probable endothelial dysfunction maybe, which eventually led to intimal dissection. So when we speak about spontaneous coronary artery dissection, our biggest question here would be that whether we want to go ahead and then stent or just leave it alone. In this case, we are dealing with a patient with ongoing ischemia, ECG changes, patient was actually having chest pain, hence we decided to intervene. So the strategy is when we want to stent, perform a drug-eluting stent for this kind of dissection, we want to extend the stent at least 5 mm proximally and also distally. But what the issue that we're having here is a very long diffuse disease dissection when extending distally, and we did not want to extend stent further down. So we decided to use a hybrid strategy here with the usage of drug-coated balloon and also drug-eluting stent. And yeah, the usage of IVUS was truly a game changer here. First, in making the diagnosis, and secondly, in confirming the wire position that we are truly in the true lumen. Thank you very much.
And nice presentation, good solution. It's if you look into the literature, it's always a discussion and there's no clear answer what you should do with spontaneous dissections that more frequently occur in women than in men. And some leave it alone, some work on it. I think your final result describes the possibility of doing an intervention. Did you, and I'm not sure whether it's related to COVID, you could think so, but as I understood, he has diabetes, so there will be endothelial dysfunction probably. Dysfunction, yes. It might also be a cause. And did you consider to leave it alone only with drug-coated balloons or only with balloon angioplasty? In the past, I used to do that sometimes and then bring the patient back another day or before leaving the hospital for re-angiography and to see how it looked like. Sometimes you saw beautiful arteries afterwards with no lesion at all. So I think you did a great job once again, but I'm just asking you, did you consider any other solutions? And again, I think the introduction of IVUS has helped us a lot over the last 10, 15 years.
Yes, so Jacques, actually, we have quite an amount of experience in using drug-coated balloon, not only in cases of spontaneous coronary artery dissection, but in all our long diffuse disease, somewhat in our large vessels too. We do restudy them back in about 3 months. Then we realized that there is a late luminal gain, very good positive remodeling. Hence, we decided to use this strategy in our case here.
Okay. Any other comments from the panelists? Or Marco?
Yeah, I actually have a sort of question about the use of DEB in the spontaneous coronary artery dissection. As you know, in patients with spontaneous coronary artery dissection, the coronary artery usually is normal most of the time, and then I'm not sure whether it will be just a balloon angioplasty will be enough for that, because I'm not sure whether it works, because there's no lesion there for you to do for the drugs to work, because this is just because of the dissection. That's why the lumen is occluded. So what do you think about the comment, Dr. Sundaraju?
So there was also in our mind actually, but we realized that this patient is diabetic. Yeah, like what Dr. Jacques said, there can be some amount of endothelial dysfunction here. So we thought some amount of drug that is being released here will be quite helpful later on if there is some amount of disease there. And so we decided instead of COBA, the DCB instead.
Yeah. So the other thing is about this spontaneous coronary artery dissection. They always worry about extension of the intramural hematoma. I think in your case, it's quite sort of lucky that there's no extension of the hematoma into the peripheral branches. So the final result look actually excellent. So what happened if you do have a hematoma in the PDA or PL branch? What would be your solution?
No matter what, we have to conceal the hematoma. Hence, we have to extend the stent. Yes, it is a very small vessel. Probably I'll put in a 2O stent and extend further to both the PL and PD. But in this case, it didn't extend. Hence, we decided to just stop there.
Actually, the problem is with my experience, the more stent you put, the hematoma extends further and further to a stage at which there's no way to stent. So in this situation, I'm not sure whether the panelists have some experience. I use a cutting balloon to create a outlet for blood to come out, and then somehow the hematoma will actually resolve somehow a little bit. Yeah. So to keep standing down may not be an option. Yeah. Okay. I think thanks, Dr. Sundaraju, for the excellent presentation. Dr. Akulan, would you want to introduce the next speaker?
Yeah, it's a pleasure to introduce Andrew Parlautan from Indonesia, who will present the case of emergent thoracic endovascular aortic repair in a patient that already had undergone surgery.
Good evening to all moderator and all the panelists. My name is Andrew. I'm from Indonesia. And allow me to present a case with title Emergent Thoracic Endovascular Aortic Repair in patients with flying elephant trunk after ascending and total arc replacement. I have nothing to disclose. So for the case illustration, we have 52 years old male, came with the chief complaint of the chest pain. The pain characteristic appears suddenly at rest with high intensity with fast score 9/10 and also a tearing sensation. Patients had previous risk factor of hypertension with uncontrolled blood pressure and also a heavy smoker. From the physical examination, the patient is fully alert with the blood pressure is 130/80 millimeter mercury, with the respiratory rate is 22 and the saturation was 90-70% in room air. From the blood result, we get the decreased hemoglobin level of 10 and also an elevated D-dimer level of 5,000. And from the echocardiography, we can see that there is still good ejection fraction with 96% and also a trace aortic regurgitation. And we can see the intimal flap in the ascending aorta. We can see here from the chest X-ray that there is an enlarged mediastinum with the suspicion of the aortic dissection. So at that time we did the CT angiography, and we can see here that from the CT angiography that there is a Stanford type A aortic dissection, the Debicki one, in the ascending and descending aorta extending into the abdominal aorta, with visualized intimal flap between the proximal brachiocephalic artery and also the abdominal aorta, forming the classical aortic dissection appearance, the double lumen appearance, and also with the intramural hematome. The patient was sent to the critical care unit, but when in the critical care unit there is worsening condition of this patient, the patient suddenly have the rapid increased breathing with the respiratory rate 40, and then we decided to intubate this patient and did the chest X-ray evaluation. And from the chest X-ray evaluation, we can see that there is a worsening condition from the previous one. We did the CT angiography, and now we can see here that there is the Stanford type I aortic dissection, the Debicki one, but this time we can see that there is a content rupture in the descending aorta. We know together that from the guideline for the Stanford A aortic dissection, the urgent surgery still remain the recommended therapy with the class recommendation and 1B. So at that time, from the heart team, we decided to the semi-hybrid open surgical repair with the emergent ascending aortic and total arc replacement with the flying elephant trunk, and followed by the TFAR, thoracic endovascular aortic repair. This is the procedure. After the surgery, the patient was sent to our cath lab, and we can see here from the first video that there was very mobile, the elephant trunk from the proximal part. We can see here, and we can also see here that there is a content rupture in the ascending aorta. At first, we try to cannulate the distal part from the proximal. We can see here that we tried it several times, but unfortunately, the attempt was failed because the wire always entered the false lumen. We tried several times. We can see it from the first video that the wire always entered the false lumen into the rupture part. Because of that, we changed the plan, and then we tried the cannulation, but this time from the distal part, from the femoral access. And we can see here that finally, after several attempts and maybe some luck, we finally cannulate the proximal part. We can cannulate the elephant trunk. This is very challenging because we can see that the elephant trunk was very mobile. And this is confirmed from the aortography that the wire was in the true lumen. After that, we deployed the aortic stent graft. The first one we deployed, and then we retrieved the olive tip after deploy the first aortic stent graft. But we can see here from the last video that after the first deployment of the first stent graft, we can still see the embolic type 1B. So we decided to do the second deployment of the second aortic stent graft. We can see here that we add second aortic stent graft overlap with the first stent. And then after retrieval the olive tip, we did the aortography, and we can see here that there is no more embolic was seen from the aortography. After that, we did the CT angiography, and we can appreciate here that there was a successful procedure with the emergent ascending and total arc repair with the conventional elephant flying, the very mobile elephant trunk, and this is the final result. I think it's a quite good result. So for the conclusion or the take-home message, we can see that frozen elephant trunk is still the main choice in this case, but due to its unavailability in our country, make the conventional elephant trunk is an option, even though it's very challenging to do it because it's very mobile elephant trunk and it's very difficult to cannulate it. I think that's all. Thank you for the opportunity.
Very interesting case, very good job, and well performed. I really do appreciate this. Congratulations with your good work. Any of the panelists does have any comment? We're all impressed, it seems to be.
I'm just want to ask, because this is young patient, and if you see the aorta is really dilated and tortuous, did you try to find out what is the cause, any cause for this dissection? Any sort of connective tissue disease that causes it, or?
Actually, in this patient that, thank you for the question. Actually, in this patient, we didn't know, but as we know together that this patient have a very high blood pressure with an uncontrolled blood pressure and also a heavy smoker. So at that time, we just think that maybe that's the risk factor for this patient, doctor.
Okay. Any other questions from the panelists? I think most of us may not have enough experience in this area.
I agree.
Yes.
But I'm impressed once again.
Yes, yes, very impressed. Yeah. Okay, thank you, Dr. Palautan. Let me introduce the next speaker. Again, is from National Heart Center, National Heart Institute Malaysia, Dr. Afif Ashira. The topic is third instant risk stenosis in 5 years. Are we doing enough? A role of intravascular ultrasound and lithotripsy in severely calcified instant risk stenosis. Dr. Ashari.
Okay, so good evening. My name is Afif Ashari. I'm from the National Heart Institute Malaysia. Today I'll be presenting a fairly simple case of instant risk stenosis and a recurrent one. And this case will demonstrate the importance of using ultrasound and debulking procedures in calcified ISRs. So I have no disclosures. So this is Mr. SS, a 69-year-old gentleman. He has a long-standing coronary artery disease in which he had an inferior MI in 1998. So the index stenting angioplasty was done in 1998, the RCA and LAD, and had few events and had PCB to the LAD twice in 2016 and 2019. So he has a background of type 2 diabetes, fairly well controlled, hypertension and CKD class 3A. So he was admitted this time, about 2.5 years after the last angioplasty with frequent typical chest pain. So he was treated as unstable angina. The ECG didn't show any remarkable changes, no SD or T wave abnormalities, and troponin is negative. The renal function is fairly normal, and this is the ECG at presentation. So the transthoracic echocardiogram revealed septal hypokinesia with a borderline normal LV function, normal RV function, and no significant valvular abnormalities. So looking back, this is the final results of the 2019 angioplasty. There's a question when we look back at, in this case, whether the LAD still doesn't look very well open despite the DCB treatment given at the time. So as you can see from the 3-picture post DCB, before and after, I mean, they opened it up with a 3O balloon. We didn't have the details of how much of scoring. I think they used a fairly aggressive scoring and NC balloon before the DCB, but it just couldn't achieve enough lesion preparation, but they still proceeded with DCB at the time. So this is the current angiogram of this admission. And you may say it's not much different from the last angiogram in 2019 post DCB. We were also thinking the same thing. Is this significant? Should we do this lesion? But patients still came with frequent typical chest pain. So this is the right side with the inferior MI stented. This is fairly normal with no significant ISR. So the thoughts at this point is the significance of the diffuse borderline lesion at the proximal LAD segment. This is a very old stent. The index stenting was done in 1998, and we definitely think about using IVUS in this case. And we suspected also a calcified ISR lesion. So, I mean, with atherectomy or rotablation, some people may think it's a relative contraindication. So we thought about IVL as this is relatively newly available in our center at the time. So before we proceed, we have a QFR and we confirmed the significance, and this showed 0.71, and we decided we have to angioplasty this lesion. So as the previous results we thought wasn't fully satisfactory, we definitely cannot stop by just using scoring NC balloons. So we decided to opt for intravascular lithotripsy for better lesion preparation before we DCB the lesion. So this is the IVUS of the LAD showing the MLA of 4.61 mm squared with 63% plaque burden. It's very calcified. We cannot really find any mechanical cause of the ISR, but we have to say that there's heavily calcified, so we cannot really see the old stents very well. So multiple circumferential areas of calcification, especially at the near the ostial LAD. So we did 80 pulses from the proximal to mid LAD, but focusing more near the ostial segment where it wasn't open very well last time. So post IVL, there is already showed some better luminal gain and multiple cracks seen on the IVUS. We performed further sequential predilation with the Wolverine and Scorfax and C balloon. And at this point, we thought the result showed better opacification, especially compared to the 2019 result. So after this, we proceeded to use a sequent please balloon, 3.5, a bit bigger than the last angioplasty, 30 mm just to cover the whole length of the stent. So the final IVUS showed, especially near the ostium of the LAD, the CSA has already improved to near 7 mm squared, and we thought this was an acceptable result. So these are the final shots from the angioplasty. I mean, we accept that this is the old stent. There's a lot of tissue proliferation going on, but we thought this was a adequate and a good enough result at this point in time. So hopefully he wouldn't have come with any ACS events in the near future. So we also confirmed with QFR post-procedure, and the QFR has improved to 0.93. So in conclusion, this challenging ISR lesions will challenge us more in the future. There will be more older stents, 20, 30-year-old stents in the future, and we'll be challenged to decide how to manage this complication. So IVUS is definitely key to decide on adjuncts required, in this case for the calcification, and we decided to use IVL rather than atherectomy. There may be questions about using orbital atherectomy because of the diffuse nature, but we chose IVL because there's only spot areas of heavy calcification, especially at the ostial segment. So we focus our IVL near the ostial, but we did it throughout the whole stent area. So the other one is the utility of quantitative flow reserve to assess borderline lesions. In this case, we initially thought whether we can leave this lesion alone, but we confirmed it with QFR or value of 0.71 before we proceeded with IVL and debulking procedure for the DCB angioplasty. I think that's all from me. Thanks.
Yeah, thank you, Ashari, for the presentation and very interesting case and the use of IVL in calcified in-stent wrist stenosis. Panelists, do you have any comment?
I'd like to make a short comment. As you know, there are initial procedure-related in-stent restenosis, and there's patient-related in-stent restenosis. I think you solved one problem you solved in an excellent way by performing the procedure you did do. But I have a little bit of a provocative question now, and I think you expect that one. Did you or do you consider seeing that this patient has diabetes, patient-related cause of in-stent restenosis? Did you consider Lima grafting of the peripheral LAD?
At this point in time, I mean, we didn't. I mean, that is certainly a consideration, but we seldom refer patients for our mid-cap surgery in our center. And this patient, certainly, I think if this patient presented with further ISR lesion despite IVL, because IVL is a new thing that we haven't attempted with the patient. So we thought of using this as a sort of kind of bailout for the patient before we offer surgery.
Okay. Yeah, I do agree. I would have done it a similar way, but I just wanted to bring up the question just for the discussion. Yeah. Any other panelists or?
I will. Great case, but I would like to ask two questions. So the first one is with a patient with recurrent in-stent restenosis, will you consider using OCT instead of IVUS? Because from your images, you can see that with calcification and the stent there, the penetration is not good enough to study on the extent of the calcium behind the stents. And my second question is, you use a DCB after the post dilatation, or use a scoring balloon to open up the stents. And obviously you may damage the architecture of the old stent. Will you consider putting a second layer of stent, providing that now you have sufficiently opened up with a relatively big vessel, and you can see that the luminal gain is quite substantial. So will you consider putting another new DS instead of DCB only? Thanks.
Thank you for the question. The first question is regarding
OCT.
OCT. Oh yeah. Sorry, I think it's just the availability of both is available in our center, but I think it's just the familiarity with IVUS, and we have the high resolution IVUS in our center, and most of our technicians, even the operators, are more familiar with IVUS. We do have certain teams who like to perform OCT in atherectomy and calcified lesions, but just in this case, it's just a preference of the operator and familiarity. The second question about considering a DES, I think again, this is an operator decision. We had a few cases of even more complicated ISR lesions after layers of stents, like sandwich stents, and we found that mostly the luminal area will be even more difficult to be opened up in the future. So when we had this problem last time, we feel like it's even more complicated and we have to refer for bypass earlier. So based on that, I think the operator and the team decided to try with DCB first, drug-coated balloon, rather than putting another layer of stent, which may, it may be more patent, but the lumen will still be relatively small compared to what an ostial or proximal LAD would be.
Okay, I have one question. I think your center has a lot of experience with QFR. Just wondering, because when you do the QFR, because the whole from the ostium to the distal is all disease, so there is no normal reference segment. So is the QFR correct, accurate with this sort of situation?
Yeah, there is a question on that. It will be probably not be a truly validated QFR because of ostial and diffuse lesions. Sometimes it's not the best way. Of course, we would have, using FFR might have been better in this case. But I think the QFR, the utility is there at our center, and it's relatively new. We are collecting data and looking into this. There are cases that we perform both, and sometimes we do especially those who are negative, we still do a functional study afterwards, and maybe later on we'll get more data on the QFR, we can validate them better.
Okay, thank you. Dr. Kulan, you want to introduce the next speaker?
Thank you. Well, the next speaker will be Harinder Bali from India, the Paras hospitals, and it will be a complex main stem lesion handled with 2 catheters. We're interested to see it.
Thank you. Good afternoon to all of you. I'm Dr. Harinder Bali, Chairman Cardiac Sciences, Paras Hospital, India. So, percutaneous intervention in a complex left main trifurcation lesion. We've been doing trifurcation lesion for a long period of time. Normally need 8 French guide catheter. So alternative is that if we can use 2 guide catheters to take care of this trifurcation, we can make this procedure a relatively simple one. So my patient is a 76-year-old female. She presented with class 3 angina, a known case of diabetes and hypertension, which was controlled with medication. We did our angiography, which showed a left main distal segment calcification involving the ostium of the left circumflex. We'll see the angio shortly. The LAD was a type 3 vessel. There is ostial, some disease, mid and distal segment was normal. Diagonal was normal, ramus was normal. L6, as I said, is the dominant vessel with the ostial calcific lesion with 99% stenosis. Obtuse margin was normal, right coronary was a non-dominant vessel. Now this is the angiogram, and we can see the left coronary system, the left main distal disease, distal left main disease. The circumflex is dominant, critically narrow calcified lesion. The ramus has some insignificant disease at ostium. The LAD has an ostial about 40 to 50% disease. And we discussed various options with the surgeon, with the patient, and then we decided that we should go ahead with an angioplasty stenting of this trifurcation lesion. These are the various other views which you can appreciate. The critical circumflex lesion, almost to me, 2 flow in the circumflex lesion. So we chose both the femoral root, right and left, and used 2 guide catheters. And this is how we went about. These are the 2. We put in across the lesion. It was a little difficult to cross the circumflex lesion, so we had to use a filter XT wire, and we put in a wire in the LAD. And we did angioplasty stenting with a cutting balloon first, and then high pressure NC balloon of circumflex vessel. And after we had seen that the lesion was very well dilated, then we put in a onyx stent. This is a 4 into 28 millimeter onyx stent into the circumflex to left main. Then the stent dilated well. Then we did the first spot, and this spot was with a 5 into 8 millimeter balloon. And then we crossed the lesion into the LAD and did balloon angioplasty of the ostium of the LAD. And you can see that we have 2 guides here from both the femoral roots, and then we deployed a stent in the LAD, the TAP technique, and we have a wire in the ramus also. After deploying the LAD, then we did first a kissing balloon angioplasty of the ramus and LAD, and then kissing balloon angioplasty of the circumflex and the ramus, and then finally we did a tissing with a 3 millimeter balloon in the LAD, 4 millimeter balloon in the circumflex, and 2.5 millimeter balloon in the ramus branch with about 12 millimeter atmospheric pressure. And then we did a final second part, the left main with 5 into 8 millimeter balloon. And this is what we have, the final very good flow into the circumflex, no residual stenosis. The ramus is flowing nicely, and LAD is also flowing nicely. So we have a stent in LAD, we have a stent in circumflex to left main, and we run a POBA of the ramus with a tissing, and using 2 guide catheter bed procedure, very simple, and that is what I think is way to go forward in such type of complex trifurcation lesion or left main. So left main trifurcation lesions are complex, requiring expertise and intervention, and good results can be achieved by using trifurcation angioplasty stenting using 2 stents. Thank you. Thank you very much.
Thank you. Very interesting case. Well performed. Final very good result, I should say. Do you, in cases like this, consider a larger bore guiding catheter instead of using 2 guides? I'd like to hear your opinion on that, like 8 French or 9 French if available.
Yeah, we used to use the 8 French earlier, but the problem is that you still have to use a lot of force pushing 2 stents and sometimes 3 balloons together. So this is a relatively simpler procedure than using a large bore guide catheter. But that is the change we have made now. But earlier I never used a 9 French guide, but 8 French we used earlier for trifurcation lesion. But I think this is a much simpler and more patient-friendly technique than using a large balloon.
Maybe less twisting of wires, don't know. Okay, anyone of the other panelists or my co-chairman want to make any remarks or questions? Otherwise, I leave it to the moderator, my co-moderator.
You're just asking, so you actually intended to do this triple kiss. That is why you use the 2 guides, right? For me, if I'm doing this procedure, I to make it less complicated, the OM branch is not that big, so I will have just concentrate on the LAD and the circumflex on that. So make the procedure a little bit less complex. Yeah.
I think this ramus was a significant vessel. This was at least 2.5 millimeter vessel. So I thought that that needs to be preserved. And the idea was to do a provision. And we did only balloon last year, the ramus. Finally, we did a dissing. We did not put in 3 stents. So I thought we should do all efforts, take all efforts to preserve that ramus vessel as well. So that's why from beginning it was that we would be doing a dissing. That is why we went ahead with the 2 catheters. LAD and circumflex, if the circumflex, the ramus had got pinched or occluded, then that would have been a little challenging if we were using one guide. That was the idea behind using 2 guides and preserving all 3 vessels. I would not have ignored this ramus. The answer to your question is I would not have ignored this ramus. I would have kept one after that ramus. Try to preserve it.
Yeah, of course, we would try to put a wire to protect it, but the provisional means that you don't do a kissing. That's how the definition of provisional is. Yeah. Anyway, its final result is excellent. I think that is one way that if you need to do a triple kiss, there's one way to do it rather than using a bigger guide. And the access of the vascular access maybe have a complication as well if you use a bigger ball ship. Yeah, and then a transradial and a femoral 6 French can finish the job like Dr. Bali's case, which is done in an excellent manner. Any last comment or question before we end this session? So if not, I would like to thank my co-moderator, Dr. Kulun, and panelists and all the 5 presenters for these very interesting sessions. We have presented a few varieties of condition in a TAVI case, which dislodged iliac stent, which is very skillfully retrieved, a SCAD, spontaneous coronary dissection, which is beautifully done with DEB as well as a stenting to restore the blood flow. And we have a very complex hybrid procedures for the aortic dissection, which have a very good results. And we have IVL in recurrent in-stent restenosis calcification, again with excellent result after DEB and IVL. And the last case, which is Dr. Bali presented a double guiding catheter for a very complex trifurcation left main disease, and which teaches how to use this technique for if we need to do a trifurcation lesion. So I'd like to thank everyone for your opinion and comment, and I would like to end this session here. Hopefully, everyone have a good sessions for the rest of the sessions. Thank you.
Thank you.